Dear colleagues, dear listeners, welcome to episode 1 of the Under the Skin podcast.
Welcome to the brand new series of the Under the Skin podcast, supported by UCB and hosted by Professor Monika Arenbergerová.
My name is Monika Arenbergerová. I work at the Charles University in Prague, in the Czech Republic, and I will be your host today. We will have 3 episodes, and we will start with the first episode about the new updated S2k Guidelines. In the second episode, we will speak about the combination of systemic and surgical treatment. And in the third episode, we will speak about the role of ultrasound in the assessment, therapy, and also diagnostics of HS. So the first episode will be devoted to S2 updated guidelines HS. This is my pleasure to welcome here my guests, Dr. Aikaterini Liakou and Dr. Alejandro Molina. So could you please introduce yourself?
Hello, Monika. It's very nice being here with you. Hi, Alejandro. My name is Aikaterini Liakou, but all my friends call me Katerina. I am working in Athens, in Greece, in Andreas Sigur's Hospital, which is a specialized hospital for skin diseases. I've been working on hidradenitis for the last 12 years. And I'm also an associate professor at the medical school in the University of Nicosia in Cyprus.
Hello, Monica. Hello, Caterina. It's a pleasure to be with you. I'm Alejandro Molina. I work in Granada, Spain, at Hospital Universitario Virgen de las Nieves. And I also associate professor at the University of Granada. I have been working in NHS from 10 years from now.
Okay, thank you so much. So let's jump into the first question. Ekaterina, we know that these guidelines are updated, and the last guidelines were published 10 years ago. So what are the main updates in these guidelines? What is the most important change for you, for your clinical practice, for your patients?
Look, Monica, as you're saying, it's a very important step, 10 years after the last guidelines, to have the new ones. There are many differences, but I think the most important differences to begin with is, first of all, that the disease for the first time is classified into 2 different forms, okay, into an active and an inactive form, or inflammatory or non-inflammatory form. So we divide the disease for the first time into 2 different forms, which is important. Why? Because first of all, we assess the severity of the disease with a different score according to the form. So, for example, we assess the active form of the disease with a clinical score called International Hidradenitis Suppurativa 4 score, or otherwise as an abbreviation IHS 4 score. So we assess the severity of the active form of the disease with the IHS 4 score, and we divide it into 3 stages: mild, moderate, and severe disease. Whereas the inactive form of the disease, we measure it with the older and traditional and very good one, of course, Harley staging. So the inactive form, we divided into 3 stages according to the Harley stages. So into Harley 1, 2, or 3. So we have 2 different forms, we have 2 different clinical scores, and of course, we have a different treatment. Because when a patient has an inflammatory disease, then we really need to give an anti-inflammatory treatment. We need to give a medical treatment to control the inflammation as soon as possible. Whereas when the patient has an inactive disease, then we need to proceed to a surgical approach. We need to operate the damaged skin tissue to remove all the scars and the irreversible lesions that the disease makes. So these are for me the main differences of the new guidelines compared to the older ones.
Alejandro, Ekaterina, she spoke about the diagnostics mainly, the difference between IHS4 and the Hurley system. But according to the medical treatment, what are the biggest changes for you?
The new guidelines recommend that we treat and monitor the HS patients with these scores, the HS4 and the Hartley staging. And one important thing about the HS4 is that when a patient had a single draining tunnel, a single fistula, they are categorized at least as moderate. So that's a big step to perform an early treatment approach. And then we have also to consider that patients do not only present inflammatory or structural lesions. They usually combine both inflammation and also structural lesions. So we usually have to use both index when we assess a patient, HS4 and Hartley stagings, because draining tunnels usually drain, but also they get inflammation. And I think another important thing of the guidelines is a focus on draining tunnels. Why are they so important? They are chronic lesions that produce pain, drainage, and bad odor. As a result, they produce a significant impairment on quality of life that lead to physical limitation, fatigue, depression. And from a biological point of view, they act as chronic reservoirs of inflammation, so they could also help to progress the disease. So capturing all this information, we can perform early treatment approaches in line with the severity of the patients. The guidelines also include updated recommendations regarding approved biologics to treat moderate to severe cases. But if you want to listen more about this, you can listen to the episode 2, because that's centered in the personalized treatment approach to HS. And at the end, it's not only about counting lesions and objective disease severity. The focus has shifted to a value-based medicine with a strong emphasis on the patient perspective. And this is reflected in the guidelines. They recommend us to place the patient in the center of the conversation. So we develop a treatment plan that aligns with the goals of the patients. And to achieve this, it's very important that we use patient-reported outcomes like the LQI and HiSQOL. And with this information, we can truly develop a personalized treatment plan. We want that patients are active players when we develop their treatment plan.
Thank you so much. And before we get to the biological treatment, we know that we should pre-treat the patients with antibiotics. Is there any significant change in recommendation of antibiotics in this new guidelines? So what is for you so important?
Yes, you know what, Monica, first of all, I would like also to say that it is also the first time that the treatment for example, in the active form, the treatment for the moderate and the severe disease is the same. So for the first time, we can begin the same treatment from stage 2 or from a moderate disease and also the severe disease. So this is important, that this is the same treatment for moderate and severe disease in an active form of hidradenitis. And about antibiotics, it is important to say also that after one cycle of antibiotics, so after a period that the patient has not responded to a cycle of antibiotics, then we can move on to a biologic treatment. So we can begin with 1 or 2 or 3 months of antibiotics, but if the patient does not respond, then we can and we should move directly to an effective treatment for our patients.
Thank you. Alejandro, we know that HS is a chronic disease, but it's absolutely important to start the treatment timely. So we speak about a window of opportunity. How the window of opportunity is implemented in these guidelines?
I think that the concept of the window of opportunity is not new in HS, but we never had a specific criteria that draw us where is the window of opportunity. And for the first time, they are described in the guidelines. We have a chapter that is eligibility for biologic molecules and drugs. And we have different scores, including the HS4, as I said. So a patient moderate, which is a HS4 of 4 with a draining tunnel, 2 abscesses or 4 inflammatory nodules, it's eligible to biologic treatment. That doesn't mean that all patients are going to receive biologic. This decision should be individualized and after a comprehensive examination, but it's a truly revolutionary change that we have the opportunity to think about it when we have a patient that is starting to progress, because antibiotics may improve symptoms, but there is an increasing evidence that biologic therapies could modify the disease course and will change the life of the patients.
And you know what, Alejandro, if I may add, you mentioned something about the patient-reported outcomes, okay? How important it is that the patient says himself or herself how much this disease burdens their everyday life. Okay, for example, I had a patient coming into my clinic 2 days ago, a female patient. She came in and she said, "Doctor, please help me. I am at work," and sorry for saying that, and the colleagues say that sometimes there's a nodule coming in the area, in the workplace, and I feel very badly about that. I don't know what to do. I have explained that I have a disease called hidradenitis, but nobody can understand me, and nobody can understand what it happens when I am on a flare, what it happens when I have pain, when I am suffering from the disease, okay? And please help me. And for example, this patient had 3 nodules and 1 abscess. Okay, so this makes an ITS 4 out of 5. So a moderate disease, okay. And she has already received a cycle of antibiotics without an effect. In this patient, for me, it is a moderate disease, but for her, it is her life. She really suffers so much from this. And I decided to directly start with an anti-inflammatory treatment for my patient, okay, to make her feel better and to make her feel safe at her workplace. So for me, it is very important to, as you said, to implement the point of view, the opinion of the patient about how much the disease burdens her or his everyday life.
I absolutely agree. Thank you very much for this case. And Alejandro, so we have heard about this case. You are very experienced. You have a lot of patients with mild, moderate and severe HS. Could you also tell us about a specific case where you think that the new guidelines changed your diagnostic and therapeutical thinking, the way of thinking, or how you proceed with the treatment to this patient?
Yeah, I think that there are different scenarios. I think that the most important is the early treatment. And we are dermatologists that we are specialized in HS, and we are seeing a lot of patients with HS, but this is for all dermatologists. And it's very important to share this message, because we don't need anymore that the patient need a hardly 2 stage. With a patient, as you already commented, a patient with a hardly 1 stage is eligible for a disease-modifying treatment. And many dermatologists don't know how early is this early. They think we need hardly 2 stage, some draining tunnels. We look forward to avoid this type of lesions. And another scenario that is already also very well described in the guidelines is patients with a very severe disease with a lot of draining tunnels, where the combination of surgical treatment and medical treatment is essential. And how to perform this anti-inflammatory therapy, then doing the surgery, the type of surgery. So I think that most cases of patients, including a special scenario like pediatric patients and pregnancy, are covered by the guidelines.
We know that HS is the disease maybe with the longest diagnostic delay. It's said that from the beginning, from the first symptoms up to the diagnosis of HS, it's usually around 7 up to 8 years. Do you have the feeling, for example, in Greece, that with the rising awareness, so this interval shortens a little bit? So can you tell us a positive message about this?
That's a good question, Monika. You're right. It is true that we're getting somewhere. It's getting better, but we still have a long way to go. we still have a long delay in Greece for the diagnosis of hidradenitis. There are many physicians who do not recognize the disease early enough, unfortunately, because you should think that the patients do not always go to the dermatologist, okay? They very often go to the general practitioners, to internists, to surgeons, to gynecologists, so to different specialties who cannot really recognize the disease. But I should say here that also dermatologists sometimes either do not recognize the disease early enough. And so there is still a diagnostic delay. It is still, I think, about 7 years in Greece. This is still long because when the patient receives finally the correct treatment, then it's sometimes too late, because then already the irreversible lesions of the disease have appeared, like the draining tunnels, scars. So, and there, it is sometimes it is a bit late. So we need to diagnose the disease as early as possible. We need to begin with a treatment as early as possible, so to prevent the damage, the final damage that the disease causes. And I should say on that also the patients do not know very often that they have a disease. They do not know something about hidradenitis. Most of my patients, they come to me and they say, I think I am alone in this world. I think I am the only one who has this disease. And I'm telling them, no, you're not alone. There are a lot of people having the disease, And sometimes when they recognize and they hear, oh my God, there is a disease and there is a treatment about this, and then they begin to talk about it in their, in their family or in their colleagues, and somehow, I don't know, somehow also new patients appear, you understand? Somehow another person says, oh my God, this is something that I also have. Oh my God, this is something that my brother or my sister has. And I don't know, either the patients do not recognize the symptoms of the disease. So we should work on disease awareness very hardly.
In our center, we have implemented a strategy to try to decrease the diagnostic delay. The GPs have to send all the patients to the dermatology department through teledermatology with pictures. So we receive all skin lesions of whatever, seborrheic keratosis, melanocytic nevi, and we receive also the patient with HS. And we have studied it, and the GPs identified more or less like 60% of the cases. 60%. They say that that's an HS, but the 40% remaining, they don't know what they are sending. They say folliculitis, recurrent abscesses, but they don't know that's hidradenitis. But we are capturing them because they are referring the pictures, and when we see the picture, we say, okay, that's an HS, and we make an appointment with us, and that helps to decrease the...
And do you think that after implementing the system, the diagnostic delay has been
we are getting much more early patients, young patients. So we also get some patients with Halley 2 and Halley 3 stages, but we are getting many young patients with typical inflammatory nodules and abscesses for the first time. They go to the GP, and previously the GP prescribed antibiotics and send them to home. But now, as they have the opportunity to send the picture, it's not like consuming. They make the photo, and we ask in 24 hours. So even if we want to prescribe a topical treatment or an antibiotic that is indicated, we can prescribe it very fast, and everything goes smoothly.
Very interesting. And Alejandro, now you mentioned something also important, that most of our patients are young. This is also important, okay? When the disease begins, for example, at 15 years old or at 20 years old, and the patient comes at 28 years old, then why? Most of our patients are young. They are people who need to have a normal life, everyday life. They are people who need to work, who need to study, who need to have relationships, to have, family. So they're young people and we want to help them as soon as possible. That's important.
But I also find, Katerina, that when we have young patients that they are starting to progress, and we propose them using a biologic, sometimes they are reluctant because they are not aware of the disease severity. I feel that when I treat a young patient within the window of opportunity, sometimes they say to me, "Oh, you are going to prescribe me an immunomodulatory drug for years? I'm not sure." And when the patient says that, I say, "Oh, I'm doing well." I give them some time, information. I also find that ultrasound helps because when they see what's happening under the skin, they become more aware. And at the end, it's a discussion and a shared decision. But when that happens, I think that I'm doing the things good because the disease is not so burdensome for the patient. But I'm seeing that they are starting with the first tunnel ultrasonographically, and you are modifying the disease in an objective form and also in a subjective way.
I find too that ultrasound is a very useful tool in the everyday clinical practice. I find also that it reveals the depth of the lesions and also how big and how deep the lesions are, how wide. And you're right that we see how the disease reacts under the skin. And this helps, of course, also our patients to understand that it is not only what they see, but it's also what happens below. And also that it's a systemic disease, okay? I mean, it's really an auto-inflammatory disease. As you say, my first consultation also always lasts 45 minutes to make the patient understand how the disease progresses and how important it is so that they receive the right treatment.
So the ultrasound is going to be the topic of the episode 3, but anyhow, I would like to ask you, because you are experienced with the ultrasound, so how often do you stage up? Do you shift your patients, for example, from stage 1 up to stage 2 or from stage 2 up to stage 3? How often does it happen?
I don't have a concrete number, but for dermatologists that are starting with the ultrasound, and they think that this is a time-consuming technique, and they say, I'm not going to perform it in every patient because I don't have time to perform it during my consultation. I usually use it in all patients, but if you have to choose a patient to perform ultrasound, it's the mild patient. Because when you perform the ultrasound, you have the highest chance to increase the stage, either by HSS4, even by Harley, because sometimes you see an anatomical area. Usually one of the areas with the more underdiagnosis are the buttocks, and the buttocks seem to be okay, maybe with one inflammatory nodule, and then you use the ultrasound and you find that that's apparently inflammatory nodule is a tunnel that is going deeply, and that changes completely your treatment strategy. So I find it very, very useful. And if I have to choose, I will starting by every mild patient, then moderate, and the severe patient at the end they are severe, and we are going to use our higher standard of treatment. But it's also useful to monitor the response in tunnels and everything.
No, that was something new for me. I was,
Absolutely.
I was thinking to use ultrasound in the severe patients, and now you're saying that I should begin from the very mild patients.
If you have to choose, because you have more to gain and change in the treatment strategy for that patient. Because if you think that patient has just for 3 and hardly 1, and maybe you use the ultrasound and you find a tunnel that is not clinical but is ultrasonographically present, you maybe completely change your treatment strategy.
I was surprised because I used to use ultrasound only in the early stage 3, exactly. But finally I found that it's just for nothing because the whole area is consumed by HS. But where it's really beneficial is at the HS or early stage 1 or IHS4 mild form, because you have only one nodule. The patient comes, oh, it hurts, it's one nodule, and you may perform the ultrasound and you find another tunnel in the depths, or you find another structure which is not seen because it's not painful at that time, exactly. And you don't see it. Exactly. So this is really good for the patients to persuade them or to tell them you need the biological treatment because your stage is much severe than you think. I think this is so important. Yeah.
And yes, and we should think also that they're not always draining tunnels. They are like inflammatory, and the channels that they
before draining is inflamed and has no opening.
Exactly.
So it's like a longitudinal lesion, but it's going to drain in the future. But you are detecting it before draining. So.
So Katerina, can I ask you, so you're very experienced with all ages patients, mild, intermediate, moderate, and also severe cases. So can you tell us about a specific case of a patient where you were implementing the new guidelines and it really helped a lot?
Yeah, Monica, I think that's what Alejandro said about the patient-reported outcomes. So the questionnaires that the patients answer about how much the disease burdens their everyday life, okay? I mean, this is, for me, the most important part. Because, for example, I had another patient, she's also a female patient. She was saying to me about the Easter period. So Easter is a very important fest for Greece. And she was waiting all time long to go to the church to celebrate the Easter days. And then she said to me, she went to the church. There was so much people in the church. And then suddenly she felt like the lesion that she had, it opened. Yeah, and she felt like, how the disease is. So she felt like it was very painful. And she felt like pus and blood coming out of the lesion. She was wearing a dress. And she was thinking, oh my God, I should go out of the church. And how to do that? Because she didn't want the other people to understand what was happening. And there were so many people. And she said to me, really, she couldn't sleep for 2 days because she couldn't stay in the church and really enjoying the time that she wanted to have. So you see, sometimes it is for us, sometimes it's everyday clinical practice and medicine, but for the patients, it's their lives. And it's important to see how they feel about that, how they react, and to help them as much as possible, okay? For example, in this patient, I began from the very beginning, okay? After the conventional treatment, I began with the biologic, to be honest, okay? I wanted her to enjoy the time with her family and her holidays.
Thank you very much for this case. Alejandro, so I think that we all three agree that the new S2k guidelines are a very positive help for our practice. But do you see some challenges? Something what is then maybe more difficult for you, to implement these guidelines into your practice? What takes more time? What is more difficult for you, for your patient, for your nurse?
I think that maybe performing all the procedures that depict the guidelines is time consuming, and maybe we need to adjust our agendas or reorganize in order to achieve this, or maybe we have to choose the most important thing according to our practice and our patients. And also in line with the case Katerina described, I think that we have to shift our minds and thinking the patient and listen to them and personalize the treatment. Sometimes it's the biologic treatment, sometimes it's the surgery. They have to need a surgery, and they can be out of the work, or they have a holiday, and that's the day of the surgery, and you have to adjust because it's a chronic disease. This is not cancer, and we have to try to adjust everything so the disease is not in the center of their life. We move the disease from the center to a lateral side, where this is not burdensome for them. And maybe not for us, as I said, but I think that bigger an important challenge when implementing these guidelines is the thing about the early treatment for dermatologists, and also for the insurance and the patients that they may perceive that the use of biologics treatment is going to increase and the direct cost of the patient is going to increase. But I think that's not true. But when we use the biologic early, there is a better and more durable response. There is solid data on that. And there is a less need of surgery. So just thinking about that direct cost regarding to the patient, they become less. And if we think in indirect costs like work loss, impairment quality of life, the gain is much more evident.
Thank you very much, guys. My guests were the co-authors of the new S2k Guidelines for HS, Dr. Aikaterini Liakou from Athens in Greece, and also Dr. Alejandro Molina from Granada in Spain. And I would like to make a small teaser also for episode number 2. We are going to speak about the combination of medical and surgical treatment. So stay with us and listen to us.